Good evening, sir.
Yeah, good evening.
सर बेटा फ्राइडे को करना है ना, आज ये यूरेथ्रल स्ट्रिक्चर पे लेक्चर है, वो देख लो सर वो सर ने ग्रुप में डाला है लिंक। जी सर। सर हाँ, व्यूअर वाला बच्चा सर।
Who is answering today?
Good evening, sir. Dr. Siddhant.
Okay, Siddhant.
So Dr.
And
Nakul.
and Nakul, na? Okay.
Yes.
एक minute,
Dr. Samit.
1 second. Samit, na?
Yes, sir.
And myself, sir, Dr. Omar Khan.
And Siddhant, correct?
Yes, sir.
So I have made you all co-hosts. So in case, anyone else is like, talking in between, we can just stop them. Dr. Gite, good evening.
Sir, good evening, sir.
Yes, today is your subject.
Sir, I am there, sir.
Yes, so actually, I was just going to telephone you, bhai, without you, we cannot start the program.
मैंने सर मैं ज्वाइन कर दिया हूँ ऑलरेडी।
Yes. Thank you.
जहाँ पे भी जरूरी है वहाँ पे पूछता हूँ सर।
Yes, we just wait for 2-3 minutes.
Yes, sir. Yes, sir.
Yeah. Good evening, Pankaj Bhai.
गुड इवनिंग सर।
अच्छा पंकज भाई, अपना जो बुक है,
हम्म
you have made it ना? I hope all the students have these books.
इवन आई होप सो सर।
हाँ, so you can at the end of this lecture ना, you can just show them which book by USI and you have been published, and from where to get it.
Sir, basically, this is called as clinical urology. This is available on Amazon. But best thing to do will be to ask Cipla company, and Cipla company has been distributing it to all students.
Good.
So I think Cipla, and now even if I remember it right, Sun Pharma has also taken the around 1,500 copies to distribute to all students.
Yeah,
So
because I have gone through this. It is really a very, very good book, and all the students, those who are reading it, they are telling me that it is a very good book and it is very helpful.
yes, sir. Even I agree that few sections have come up very well. Means it will need a second edition. There are some mistakes there, but I'm sure with more people reading it and pointing out the errors, we will be able to improve it much better. But yes, it has come off quite well and quite happy about it, sir.
Yes, yes.
Yes.
Okay, I think with this note, we start our today's program.
Sure, sir.
Yeah, Rahul?
Yes, sir. Yes, sir.
Yeah. So today, four of them are answering.
Yes, sir.
Samit, Siddhant, Nakul, and I believe Bhushan, correct?
No, sir. Dr. Omar Khan is answering today, sir.
Omar Khan. Sorry, Omar Khan. Fine.
Good evening, sir.
Okay. Yeah. Okay, Nakul.
Yes, sir. A
Yeah, go ahead.
34-year-old male presented with suprapubic catheter in situ for the past 5 months and inability to pass urine per urethra.
Okay. So, Nakul, let us start from you. Now, this is a history, and how will you find out the
A
further
young male
questions
with a
to find
history
out
of
a problem?
a young male presented with history of SPC in situ. So I will ask about why the SPC was placed first. So any history of prior trauma.
So what you want to know?
So whether it was
Why suprapubic was kept? So, what are the questions you will ask?
sir, whether he had any trauma, and for the same, he was placed SPC in situ because of the inability to put urethral catheter at that time, or some other reason he might be having. So I will be ruling out, sir, that the cause of this would be the traumatic or some other reason, sir.
Why you want to ask about trauma?
Because, sir,
Why?
he's a young male. Hello.
So what?
He's a
What
young
is the
male, sir.
commonest thing?
The most common would
See,
be
if you ask for the trauma first, and if by chance if this is a case of rupture urethra or something like, then the examiner will think that you know it from the beginning.
okay. No, sir,
So
because
you simple thing is you want to know whether it was acute retention, whether it was a painful retention,
Yes, sir.
or he had a prolonged history and then he was not able to pass urine and he did not have any pain, or for any other
Yes,
reason. So
yes,
these
sir.
are the two important things. If you say that way, then it's a different thing.
Yes, sir.
We can even
See,
ask whether it was
either patient can come with a history or the examiner may give you history saying that the patient had trauma and then SPC was placed, and then you take it further. In that
Yes,
case,
sir.
you are giving a scenario directly. But
Yes,
here
sir.
it is just told that SPC was placed. Maybe there was some low unit tract symptoms prior to the SPC, or what was the history. So I think you have to ask about LUTS as well as then go into detail and then maybe ask about trauma. Like sir said, directly if you are going to ask trauma, then probably examiner thinks you already know it. It is not given as yet, no trauma.
Yes, sir.
In your negative
We'll ask for.
history, you can put everything.
Yes, sir.
So
we
number
can
one, you
even
want to know what was the cause, correct? Why this suprapubic was placed. And if you are suspecting because and now second is he was not able to pass urine for urethra. Now you ask all the history. Why? What are the causes of obstruction or not inability to pass urine in 34-year-old male? What is the commonest thing?
It could be a obstructive stones or urethral calculi, because
Okay.
which patient may present with acute urinary retention. Then
Okay.
the second case would be any bladder outlet obstruction secondary to any stricture disease that can
Very good.
with
Yes.
acute retention. Uh, then, sir, vesical calculi blocking the bladder outlet. Then, sir, other causes may be underactive. Lower down the order, I would like to give if the patient is comorbid underactive detrusor, that might be the reason, or patient. Yes,
Very good. So
Yeah.
you have thought about all the multiple causes. It's very good. Now we know that you are thinking, just directly not jumped on trauma.
And then in the negative history or directly trauma, and then what are the negative history you'll ask?
no negative histories or any history of prior infection or any scrotal swelling, any history of epididyma orchitis, then any history of hematuria, lechuria, or then trauma history, then any history of surgical interventions or history of any catheterization underwent in the past, and then any history of trauma to the spine or back or any other injuries, and then any other comorbid conditions if it is present or not. Sir.
And also history of
Umar, tell us what else?
sir, any history of discharge should also be asked to the patient.
Yeah.
Sexual
And
contacts.
Any history
yes,
of flank pain, fever, burning micturition.
sir, any history of signifying if the patient is having decompensated renal function, any history of facial puffiness, or any history of exertional dyspnea or swelling of the bilateral limbs, that should also be asked if it is a case of chronic uh, obstruction.
very good. I think almost everything has been covered. So I feel chronologically you should ask that any history of pain in the lumbar region, followed by malaise and acute retention of urine. So you are ruling out this stone problem. Then patient had a lower intake symptoms for slowly and ultimately he developed acute retention of urine, which may be outlet obstruction due to stricture formation. you know then, like any history of trauma, or he had constipation, or he had any stool problem, to rule out neurological problem, and history of trauma, instrumentation, then fever, any comorbidity. So these are the way you have to ask, keeping in mind, okay, what are the causes of retention of urine.
Yes.
Rahul, show them.
asymptomatic 5 months ago when he sustained a road traffic accident, following which he developed pelvic fracture with associated left thigh injury. Immediately after the trauma, he complained of inability to pass urine along with blood at the meatus. There was no history of attempted urethral catheterization at that time, and an emergency SPC was performed. Since then, the patient has been on continuous drainage with regular catheter changes every 4 weeks. He reports complete absence of perurethral voiding since the injury, with no passage of urine through the urethra. Occasionally, he experiences a sense of urge to void with minimal but no satisfactory urinary stream. Shall I go ahead, sir?
Yeah, go ahead.
No history of abdominal or flank pain, fever, chills, dysuria, burning micturition, or hematuria, lithuria, urgency, urge incontinence, stress incontinence, nocturia, perurethral voiding, or urinary stream since injury as mentioned previously in the history. No history of catheter blockage, pericatheter leakage, or encrustations, prior urethral instrumentation or catheterization, that is history of same before the trauma occurred. No history of limb weakness, erectile dysfunction prior to trauma, and stool incontinence.
Sir, one question for them. Uh, was there any attempt? So he said that there was no attempt of catheterization. So any one of you would try to do one gentle catheterization or directly SPC?
So technically, we can try and attempt a gentle catheterization. If not, then we can go. Ideally, we can even, if there is a history of blood at the meatus, then go for immediate RUG and assess, or and try a attempt. If not, then we can go ahead with an SPC.
Very good.
So if the RUG shows if there is a passage of contrast to the bladder, then we can attempt. If there is extravasation, complete cutoff, it is better not to attempt and put a suprapubic catheter.
Okay, so let us go very systematically. So, Omar, when you come across such a case in emergency, okay, now how will you go ahead? You are called in emergency room. That patient has road traffic accident and he has got he is not able to pass urine, or they are saying that patient is having a retention and we are going ahead with other investigation. So please come, or directly he has come to you.
Sir, firstly, after general examination, we would look at his abdomen, look for any distension, any signs of trauma, or any signs of hematoma localized, and we'll also look at his meatus if there is any bleeding as such. And apart from that, we will look for the bladder if it is palpable or not. Then after that, if there is blood at the meatus, we will proceed with an RUG, which would help us decide the further action.
Only thing you missed is that when a trauma patient comes, you should say that I will see whether he is vitally stable and stabilize him. That is the most important first step.
Yes, sir.
So first thing is resuscitation, then thorough examination, and you will like to find out whether patient has any other systemic injuries, any other injury, or he has got mainly only the pelvic fracture and urinary system involvement. Then you come down to urinary system. So in urinary system, you will do a thorough examination, as you said very rightly. Okay, you will do what are the, so start from the outside local examination, whether any bruises, any hematoma, okay, bladder is palpable or not. Then blood at the meatus,
Yeah.
any other injury to the testes or any external genitalia. Then you'll do PR and you'll find out whether the tone is anal tone is proper or not, because he might be having some injury behind. And then you will see the prostate, correct? So what is the importance of prostate?
So there would be a high riding prostate if there is a rupture of puboprostatic ligaments.
Where up to which level there will be injury, then it will be high riding. at a bladder neck, at the prostatic and membranous junction, or bulbomembranous junction?
The injury should be at the level of the
The
bulbomembranous junction to cause it to make it
Membrane.
a high riding prostate over here.
And why?
Because of the detachment from the urogenital diaphragm, sir. So the prostate would be high riding, which uh, patient has not voided. Or I will again check the hydration status of the patient and the bladder is palpable. Then if the high riding prostate, then I will suspect this injury, sir.
Okay. So till now, Pankaj bhai, you want to, or Gite sir, you want to, add something or tell them?
नहीं, whenever you have been called to the casualty to assess the patient, so we have to do multiple things in parallelly. जैसे कि asking the history, assessing the general assessment of the patient, like hemodynamic stability है, instability है. उसके बाद में जनरली जो भी विजिबली टॉप टू बॉटम वन गो में वो भी चेक करना है. पैरेलली फास्ट जो फोकस असेसमेंट ऑफ सोनोग्राफी है वो भी करना है. ब्लड एटमियाटस दिखा है तो आरयूजी के लिए भी प्रिपरेशन करना है. ब्लड प्रेशर पल्स उसके साथ में हिस्ट्री भी पूछना है कि कितने कितने घंटे पहले ट्रॉमा हुआ है, कौन से टाइप का ट्रॉमा है, एक्सेलरेशन है, डिसेलरेशन है, पेशेंट चलते हुए आया है या फिर ट्रॉली पे आया है, पेशेंट ने यूरिन पास किया है नहीं किया है, कहीं पे उसके पहले दिखाया है, वहां पे कहीं किसी ने कैथेटर का ट्रायल किया है नहीं किया. ये बहुत सारी चीजें एक साथ सब कुछ चीजें करना पड़ेगी. सो दैट कि जब फिर जनरल एग्जामिनेशन बाकी सिस्टमिक एग्जामिनेशन में कोई भी ध्यान उसको भी ध्यान में देना है कि कोई जनरल सर्जिकल प्रॉब्लम है या चेस्ट प्रॉब्लम है, फ्रैक्चर रिब है, लंग कंटूजन है, लिवर इंजुरी है, स्प्लीन इंजुरी है, हेमोपेरोटिनियम है, एम्प्टी ब्लैडर है, फुल ब्लैडर है. हो सकता है कि इंट्रापेरिटोनियल रप्चर के बाद रप्चर है तो फुल ब्लैडर रह सकता है, सॉरी एम्प्टी ब्लैडर रह सकता है, यूरिन पास ही नहीं करेगा. या पेशेंट को और हो सकता है कि प्रीसेट कोई रेनल फेलियर का प्रॉब्लम है, वो भी रोल आउट करना पड़ेगा, यूरिन ही नहीं बना है. तो ये सब चीजें देखते हुए तुमको प्रोसीड करना है. यूजुअली स्ट्रिक्चर यूरेथ्रा का शॉर्ट केस आता है एग्जाम में, और वो मेजॉरिटी चीजें डायग्नोसिस एंड मैनेजमेंट पे डिस्कस होती है एग्जाम में, पर्टिकुलरली एग्जाम के बारे में बता रहा हूँ. तो जैसा भी ब्लड एडमियाटस, तो फिर ब्लड एडमियाटस है तो उसको कैथेटर करना कि नहीं करना, रिटेंशन है कि नहीं है. तो रिटेंशन नहीं है तो फिर वो पेशेंट थिक है, थिन है, हेवी है, तो कभी कभी ब्लैडर पाल्पेबल दिखता नहीं लेकिन फुल रहता है, इसलिए वो सोनोग्राफी करना जरूरी है. सच में ब्लैडर पाल्पेबल है कि नहीं है, ब्लैडर फुल है कि नहीं देखने के लिए. और तो क्वांट्रा अभी कितने लोग क्वांट्रास्ट डालते हैं. प्रैक्टिकली स्पीकिंग आरयूजी इमरजेंसी में 99% हॉस्पिटल में कहीं पे नहीं होता है, हमारे पास भी नहीं होता है. वो वंस इन वाइल जब तुमको लगेगा ही, लगता ही है कि भाई तुम आरयूजी करना जरूरी है, या फिर तुम कोई प्राइमरी रीअलाइनमेंट का तुम्हारे दिमाग में कुछ प्लान चल रहा है, ऐसे सिचुएशन में, या पेशेंट ने यूरिन पास किया है, कैथेटर डालने के पहले तुमने इंजरी का जो ग्रेड है वो कंफर्म करना चाहते हो, ऐसे सिचुएशन में यूजुअली प्रैक्टिकली करते हैं. लेकिन एग्जाम में ब्लड एडमियाटस आरयूजी करना ही है. तुम्हारे पास होता है कि नहीं होता है, तो सर मेजोरिटी टाइम होता है, ऐसा ही बोलना है, नहीं भी होता होगा तो फिर वो ऐसा, वो जैसा भी ये पूछेगा तो तुम्हारा नेक्स्ट क्वेश्चन उसका रहेगा कि आरयूजी कैसा करते. उसका प्रोसीजर फिर टिप ऑफ टंग रहना चाहिए, टॉप टू बॉटम. पोजीशन कैसा देना है, कितने डिग्री का पोजीशन, राइट थाई, राइट लेग कैसा है, कौन सा फोल्ड करना है, थाई कैसा रखना है, कितना स्ट्रेच करना है, ज्यादा स्ट्रेच करे तो क्या होता है, कम स्ट्रेच हो क्या होता है, ये सब चीजें एक के पीछे को अब तुमको खुद को एग्जामिनर को गाइड करना है. नहीं तो क्या होता है फिर एक आधी जगह पे गाड़ी अटक गई कि वहीं पे फंस जाता है पूरा.
Correct. So, suppose this patient has come to you and he has got only fracture, means you are suspecting that he has got only pelvic injury and he has not passed urine, but the bladder is not palpable. Now what will do?
So if the
First, we
bladder
will check
is
the
not palpable, I would like to know whether the patient has passed urine before or not. If the patient has passed urine, if the patient has not passed urine, first I would like to hydrate the patient, look for his hemodynamic status. Because sometimes the patient might be dehydrated. After that, if the patient has passed urine, then I would like to go ahead with a gentle attempt of catheterization. Or else I would hydrate the patient and then give him diuretic so that the bladder becomes palpable. And then go ahead for doing a suprapubic cystostomy.
It might be that the patient is dehydrated, but it can also be a bladder rupture.
Yes,
So
sir.
you should always check for acute abdomen and then hydrate the patient.
Yes.
So the most common cause will not be dehydration, but hypotension related to associated injuries.
Yes.
Yes.
So dehydration in a patient coming with trauma is very low down in your causes for partly full bladder. So hemodynamic assessment, look for if hypotension corrected, give IV fluids, observe. Okay. And see what happens. If the patient passes urine, then it is extremely important to look at the color of urine. You have to document that there is no hematuria. There may be associated renal injury when the patient has a road traffic accident. So ruling out other urological injury by looking at urine color is extremely important. Okay. Now, Samir, this
Yes.
patient or one of his relative has heard of, or sir just mentioned about primary realignment. What is there? What do you think is the status?
So before, like once after subjecting to investigation, then we can assess. So basically, if the patient right now is on SPC, so
No, no,
then
no. So primary realignment कब करते हैं? क्या है? What is primary realignment? पहले ये बताइए.
So based on the RUG findings, sir, if the degree of injury or the degree of the tear or the stricture which is there, it is not severe, but it is mild, and it is not distracting.
Hold on. अभी स्ट्रक्चर नहीं रहेगा, स्ट्रक्चर डेवलप
अच्छा,
होगा,
it's
अभी
a
तो इंजुरी हुआ है.
Injury, sir. It is mild grade, depending upon the McCallum classification, and if it is the distraction defect is not it is not a complex injury, and the distraction defect is not too much, then an attempt for primary realignment would be possible, depending upon the.
No. Siddhant,
Uh,
any idea?
The primary realignment is done so that after injury, patient would require a definitive management. It decreases the size of the stricture. The primary realignment, if done early, eventually the stricture size will decrease. So that is the main aim.
So how is it done? What is done?
Sir, flexible cystoscopy. Sir, we have to put a flexible cystoscopy from the suprapubic region as well as from the perurethrially, and we try to pass a guide wire. If the guide wire goes, and then we can take the guide wire out perurethrially, and then insert a Foley's catheter. Railroading can be done.
So you would make a suprapubic puncture, put a wire from above, manipulate the wire down the injury site, go through with a cystoscope in the hematoma, catch hold of the wire, bring it, make it through and through wire, and over that place a catheter.
Yes.
As you rightly said, so number one, it is not done for minor injuries. It is done for injuries where there is complete tear and distraction. It was one of the thoughts that probably doing primary realignment will reduce the incidence of stricture and make future procedure easy. But now ample literature to say that it doesn't work that way. The risk of stricture is also same, and the future procedures are also not very significantly different. So it is something which can be done, but probably not advocated because it doesn't add much. The negative point of primary realignment is that you are adding infection to the hematoma. So the risk of infected pelvic hematoma is very high. So the negative points are higher risk of infection, and it really doesn't make a much difference in the future prospects of the stricture or the treatment that is needed. Okay. So again,
Pankaj bhai, what you said very rightly, na? Our time we used to say three important things. Why we don't do it? Because it is a closed fracture, which you are making it an open fracture. So complicated and non-complicated. Like non-complicated becomes complicated fracture. Second thing, there is usually quite a lot of bleeding. By doing this, there may be, you may enhance the bleeding and patient may again go into shock. And the third is introduction of this infection. So these are the three reasons earlier we were not, we had stopped doing railroading.
Realignment, sir.
No, no,
So
what sir is telling is about railroading,
railroading,
and you
yes,
are
sir.
talking about realignment.
Realignment, yes, yes, yes. So just to now summarize again, if the patient comes in emergency, if hemodynamically stable, in retention, unable to pass urine, do a retrograde urethrogram. It should be done. The installation of contrast should be at a very means not pressurized installation. See whether there is a continuity of the lumen. If you see continuity of lumen, one attempt at catheter could be done. If no continuity is there, then better to place a SPC and stage. Okay. So in exam, you would say this, let the examiner ask you about primary realignment. Don't come out and talk about primary realignment.
No, I uttered this word only because there is indication for RGU or RUG.
Absolutely, sir. नहीं So good, उसी बहाने सर हमारा ये discussion हो गया.
Current status of primary realignment, as sir also told, not routinely done. बीच में 5-10 साल के लिए एक हाइप आ गया और वो बंद हो गया. जो स्टूडेंट ने बताया था वही इंडिकेशंस उस टाइम पे बताते थे कि स्ट्रक्चर का डेंसिटी कम हो जाएगा, उसके बाद में फ्यूचर में उसका ऑपरेशन में ईजी हो जाएगा. ऐसा है कि एसपीसी नहीं किया, अब सॉरी प्राइमरी रिअलाइनमेंट नहीं किया तो कुछ नहीं किया तो 100% स्ट्रक्चर है. ये एक कंसेप्ट था उस टाइम पे, स्ट्रक्चर होने वाला है. प्राइमरी रिअलाइनमेंट किया तो एटलीस्ट लुमेन का पेटेंसी मेंटेन रहेगा, स्ट्रक्चर का जो डेंसिटी है कम रहेगा, लेंथ कम हो जाएगा, ऑपरेशन को फायदा हो जाएगा फ्यूचर में. ये सब ये कंसेप्ट के साथ इमीडिएट प्राइमरी रिअलाइनमेंट, डिलेड प्राइमरी रिअलाइनमेंट, रेल रोडिंग, ये सब चीज़ें उस टाइम पे ट्राई की गई है. लेकिन in spite of doing all type of primary realignment, still there is a need of near about 70 to 80% endoscopic treatment or open surgery after doing the primary realignment also. So वो concepts अब slowly absolute हो गए, बहुत जगह पे usually लोग करते नहीं है. That सर ने जैसा बोला है वैसा कि जब तक वो पूछेगा नहीं तब तक हमको नहीं बताना. तो one attempt of gentle attempt of catheterization, तो एग्जामिनर का मूड देख के बता दो कि अगर वो बताना चाहते हो तो आरयूजी करना है, कॉन्ट्रास्ट अगर ब्लैडर में गया है तो वन अटेम्प्ट करेंगे, नहीं तो नहीं करेंगे. ब्लड एट मैटर्स दिखा है, एसपीसी कर देंगे.
Okay, good. So now, Omar, this is the situation. Now what you will do?
Sir, in this case, after taking the history and asking the patient why the SPC was done, depending upon the answer of the
No,
patient, if he
now you know better. And now from the history, you know that he had a road traffic accident,
yes, sir.
and that is the reason this suprapubic catheterization was done.
Yes, sir. Sir, firstly, we would like to proceed with RUG along with VCUG to know the length of the
You don't
stricture.
want to do examination.
Yes, sir. After thorough
He
examination
had a
only,
spine injury and he has got now paralysis.
Sir, firstly, we will proceed with the examination. We will see if there is any associated spinal trauma. We will also look for the focused neurological examination, and we would like to do check the anal tone, check the perianal sensations, and also check the BCR of this patient. After that, uh, we would also like to examine the movements of the patient for the positioning. Then, after all the thorough examination, we would proceed with investigations.
But there are
And so
many
we'll
other
check
things.
the
History is
prepuce.
completed. His
No,
history is
sir.
completed.
Sir, we will see if the we'll also check the meatus. We would also like to check
No, history is
the length.
complete.
No, sir.
He's a juvenile diabetic. No,
Sorry, sir. He is a juvenile.
Diabetic.
Okay. Sir, so
इसीलिए ना
See,
any patient if you want to tell in exam it should start with clinical examination and history. कोई भी पेशेंट तुम्हारे सामने है कि मैं हिस्ट्री पूरा ले लूंगा क्लिनिकल एग्जामिनेशन करूंगा क्यों करना है प्री ऑपरेटिव असेसमेंट to know the site of the stricture, to know the number of the stricture, to know the etiology of the stricture, to know the length of the stricture, to know there is a patency of lumen or not, कंप्लीट ऑब्स्ट्रक्शन है नहीं है, ये सब चीजें देखने के लिए और उसका वो हिसाब से प्लानिंग करना है सर्जरी का कौन सा सर्जरी लगेगा इसके लिए उसका प्री ऑपरेटिव असेसमेंट करना है. तो प्री ऑपरेटिव असेसमेंट मतलब जैसा सर ने पूछा है कि पहले तो तुम चीप कंप्लेन पूछेंगे उसके बाद में हिस्ट्री पूछेंगे इटियोलॉजी कैसा रोल आउट करेंगे मैलिग्नेंट स्ट्रक्चर है रेडिएशन स्ट्रक्चर है ये सब चीजें तो पूछना पड़ेंगे ना स्टोन की वजह से हो गया कैथेटर की वजह से हो गया ऑपरेशन की वजह से हो गया ये सब चीजें हिस्ट्री में एक के नीचे एक आना चाहिए सो दैट कि वो एग्जामिनर को लगेगा कि यू आर रूलिंग आउट ऑल द कॉजेस ऑफ द स्ट्रक्चर. और क्लिनिकल एग्जामिनेशन मतलब उसका सबसे इम्पोर्टेंट चीज अगर कोई है तो जो पेनिस को डबल डबल ब्लड सप्लाई है नीचे से और ऊपर से अगर वो एक जगह से ट्रॉमा हो गया और ऊपर का अगर डिफिशिएंट है तो उसका तो ऑपरेशन का कार्यक्रम हो जाएगा डॉर्सल पूरा कंप्लीट वल्बर नेक्रोसिस हो जाएगा तो उसका ग्लांस में कुछ नमनेस है सेंसेशन है नहीं है इरेक्शन आता है नहीं आता है ये सब ये इम्पोर्टेंट पॉइंट है एग्जाम में ये मिस करना नहीं.
Yes.
Rahul, go ahead. Just show them all the history full. Now,
Past history. Patient had history of blood transfusion 5 years ago once, and 3 PCV were transfused during the trauma management. Family history is non-contributory. Personal history is normal and bladder as described drains from SPC. Habits में he is a non-drinker, non-smoker, a chronic tobacco chewer for 6 years. Patient is not sexually active. Injury has occurred, sir.
so Omar,
Yes,
what
sir.
have you learned more? What are
Sir,
the important points?
sir, firstly, from the history, we have got to know about the etiology of the reason of the SPC. Apart from that, we got to know that his bowel habits are normal,
Yep.
and also that one more important thing is that he is a chronic tobacco chewer, and he is not sexually active since the injury. So we are not sure about his erectile dysfunction. We'll have to ask about morning erections and also his exact status of erections.
Okay, so now, what is the importance of tobacco chewing in this case?
Sir, in case as after investigations, when we plan for the surgery, and in case we want to get a buccal mucosal graft, so it would be of significance, and it would help us deciding the site of the graft.
So, in pelvic fracture, when there is a total disruption of urethra, have you seen anyone using buccal mucosal graft?
No.
Of course, if you are suspecting that, along with that, if he has got any other stricture distal to that, then it's okay.
Yes.
But
Yes.
whatever it is, this history is important. Correct?
Yes, sir.
Second thing, as you said very rightly, okay, whether he is getting, he may not be sexually active, but you have to ask him whether he is getting erections, early morning reactions, or not, or whether he's
Suppose
getting
patient is
arousal
not
at that
sure
time.
about erection, can you check? How will you check erections? Any test you will do?
Sir, for objective test, we can get a penile Doppler done if we want to document it for medical legal purposes, or an office sildenafil test also can be done. But a better would be an objective penile Doppler, which would be also helpful for medical legal purpose to document.
I think it is very important.
Sir.
Whenever there is a complex stricture or associated with pelvic fracture, or whenever you are doing a whenever you feel clinical signs and symptoms suggest of erectile dysfunction, then better to do a penile Doppler in such type of cases.
Yes.
Don't forget it. And whenever you are talking about the SPC now, you should मतलब SPC कौन से साइज का कैथेटर है, SPC कब चेंज किया है, उसके बाद में SPC कहाँ पे है, सेंटर में है, लैटरल में है, एसोसिएटेड एब्डोमिनल लैप्रोटोमी पहले किसी ने किए वाली है, नहीं किए वाली है, ये सब चीजें बहुत कितना डिस्टेंस है सिंपसिस प्यूबिस के ऊपर, ये सब चीजें अगर तुमने खुद होके बता दी तो एग्जामिनर को लगेगा कि यस ही इज थिंकिंग समथिंग डिफरेंट फ्रॉम द नॉर्मल स्टूडेंट्स.
Yes, sir. Yes, sir.
Okay, Rahul, go ahead. Show on the
General
examination.
examination is clinically normal, sir. Spine exam, limb power are normal, sir. Per abdomen, flat on inspection, centrally placed an inverted umbilicus with flat abdomen, normal abdominal thoracic respiration. Scar of previous surgery over the left groin is seen. SPC in situ in suprapubic region with healthy surrounding skin and clear urine. No sinus or dilated veins, visible swelling or renal angle fullness. No visible peristalsis. Hernial sites are clear. External genitalia is normal at present, circumcised. Should I go ahead, sir? On palpation, no obvious palpable lump or no tenderness, no renal angle tenderness. Hernial orifices are normal. No spinal deformity.
So, Omar, he is circumcised. Is it important?
Yes, sir. It is, sir. It is important. One, we have ruled out that his any involvement of this phimosis we have ruled out. The other thing is for surgery also we would require it as a preputial graft. So we have to look for alternatives for the surgery, alternative graft sites.
Yeah. Okay. Fine. So now this is now what you want to do? Percussion, auscultation, and what is a per rectal examination?
No fissure, fistula, or hemorrhoids. Perianal region is normal. Anal tone or squeeze is normal. Rectal mucosa is smooth, mobile, non-tender. Rectum empty. Prostate is normal in size, firm, non-tender. No baggy swelling or pelvic hematoma. No blood on gloves.
Fine. So now, Omar, now what you want to do now?
Sir, after finishing the examination, I would like to do some basic investigations, some basic workup, and after some basic investigations and also know the status of the kidneys, I would like to get a KFT done. And also, as an extension of the examination, I would like to get a USG KUB done, sir.
Yeah. That's showing. Just see the reports and let us know.
Hemoglobin is low.
Samit, what are the
Yes, sir.
positive findings?
So this hemoglobin is low, along with the total bilirubin and direct bilirubin, along with the liver enzymes are raised, and rest is within normal limits. So hemoglobin is 8.8, total bilirubin is 3.29, along with SGPT, SGOT is 61 and 37.
So now, can you think of anything? Will you like
So
to do
there
some
could,
other investigation from the history and these blood reports?
so there could be ongoing history of liver trauma also, so which might be
Liver trauma, 5
or
years
any.
back, blood transfusion. Now 3 blood transfusion,
Oh,
6 months back. Now raised bilirubin, SGOT, SGPT raised.
so there is maybe chronic liver disease or any.
So we will have to rule out hepatitis.
Right, hepatitis.
Ah, correct. So that is what very important, na? Okay.
Yes.
Rahul, go ahead. Show them all whatever they have asked.
So this is a urine routine of the patient, sir.
Okay. Next.
In
So
the
this is a culture.
Pseudomonas was isolated.
So Siddhant, which antibiotic you would like to give?
Your colony count is more than 10 raised to 5, and the patient is sensitive to amica sensor.
So you tell us, na, which antibiotic you want to give?
So preoperatively, injection amikacin can be given, but the rest all is resistant, sir.
So Nakul, you agree with him?
Sir, as the patient is on SPC, patient does not have any history of fever or any other uh, history suggestive of patient having any UTI or something, then I will reconfirm this urine culture again with proper sampling. If again showing the same reports, sir, then I will proceed with prophylactic antibiotics perhaps.
Which one?
So as per the culture, only amikacin.
So, sir is
Okay,
trying
fine,
to
fine.
ask you how will you select? It's only sensitivity or anything else?
So looking
So
at the renal status, hepatic status, uh, first pass metabolism, whether it is excreting by the liver or the kidneys, and
अरे
that
बाबा MIC देखोगे कि नहीं?
Yes,
yes,
sir. MIC.
Fine. So anyway, what you are saying is right. Amikacin may be a not a bad choice. So you'll start the amikacin.
Yes.
Fine. Now next, Rahul, show them whatever they ask.
This was the X-ray of the patient, sir.
Samit, you will like to read this X-ray?
Yes, sir. So this is the scout, the X-ray which shows SPC in situ. There is evidence of the bilateral inferior pubic rami fractures without any fracture of the long bones or the femur, and so there is no evidence of any other deformity seen. And so the two positive findings here, there is SPC in situ along with, and there is even diastasis of the pubic symphysis.
So any X-ray, whether it is well centralized, bony architecture, preparation, and then your findings.
Yes.
You can see
There are fragments also, no? You can see.
And bony fragments.
You can see significant callus formation at the ischial tuberosity and the pubic symphysis, which is a sign of healing fracture.
Yes.
Yeah.
Yeah.
Dr. Vinod Joshi, you will like to ask any question? Okay, Samit, this is a X-ray. Now what else you want?
So then, after giving the under antibiotic cover, I would like to proceed ahead with RUG along with VCUG for this.
So Samit, after how much time of the injury you will like to do RUG
Sir,
and VCUG?
so ideally, after the injury is already there is, so pertaining to this case or
Yeah, any case, but after injury,
so
you have done a
ideally after,
suprapubic and
yes,
then
sir.
now you want to investigate.
So ideally after 6 weeks, 1 to 1.5 months.
Anyone else? Omar, Samit, Nakul?
As per the
Samit is there.
guidelines, the
Yeah.
blood treatment should be after 3 months of the SPC placement. So once the stability of orthopedic injury or and the recovery from the same, we will proceed for investigation when we are planning for the management of the same after 3 months at least, sir.
Yeah.
Hi,
Fine.
Hi, Gaurang.
Dr. Gite, you can throw some Vinod. Yes,
Sorry,
please.
I was not very audible. You asked me about these X-rays. I think it is very important to classify into stable fractures and unstable fractures. I think this X-ray shows is a little bit stable fracture, not an unstable fracture. So the overall distraction injury of the urethra in this particular X-ray is going to be less as compared to unstable fractures of the pelvis. So I think this is an important kind of a thing to be mentioned. So there is a fracture
Yeah.
only on two sides. If there is a fracture even above also of the superior rami and the iliacs, then it becomes an unstable fracture of the pelvis.
Yes.
So, Samit, sir has, given a very important point. But
Yes.
what is the importance of that stable and unstable fracture?
As for the further management purpose and the degree of the distraction defect. So as per the management, so uh, like unstable fractures which are there would need immediate orthopedic intervention for the same.
Okay. And what is the classification?
So depending for the classification, there are two. It is a tiles classification based on the stability and young Burgess. So tiles would be grade A is normal, B is rotational instability, vertical stability, which is an open book, and C is both rotational and vertical instability. And based on young Burgess, it could be as per the anterior-posterior compression defect, a lateral defect, or a combination of both. So it is classified into anterior-posterior grade 1, 2, 3 and lateral 1, 2, 3. So in lateral, it could be isolated sacral fracture, sacral plus iliac ring fracture, and rotational instability of the contralateral hemipelvis. And for anterior-posterior, it is depending upon the disruption of the SI joint. So mild, moderate, and then severe.
Good.
Fantastic.
Very good.
Very good. Very good, Samir.
Thank you, sir.
Yeah. Fine. So now, who is going to answer me how you are going to do VCUG and RUG?
RUG first, as there is no long bone, we'll take the clearance from the orthopedics for the position. And then after that, sir, RUG would be done. First, the patient is placed in supine. We'll do a anteroposterior scout film, and then after that, the pelvis is tilted in 45-degree, and there is flexion of the knee along with the hip, and the thigh is placed at an angle of 90-degree with the rest part. And then with help of 8 French Follies or in a syringe at our institute, we use a syringe, sir, with a adapter. So just snugly fitting into the meatus with giving traction, an equal dilution of 1:1 contrast urographene we instill, and we obtain the uh, X-ray, and simultaneously, sir, there should be both. Along with that, VCUG should be done, where simultaneously there is contrast installation from the suprapubic catheters.
So how much you don't like to fill the bladder? How much you will fill up?
Sir, as
Just by pushing contrast, you will get VCUG?
no, after filling the bladder so we'll analyze on the shoots how much. So around 200 ml, we will 200 to 250 ml, we will fill, and then we will clamp and ask the patient to void, and then check the voiding film, and then again take a shoot how much it is retained, whether the bladder neck is open or not. An evaluation of the posterior urethra at that time will be evident.
So many a times you don't see the posterior urethra. So what is the ideal way? Will you like to give some medicines beforehand?
So then alpha blockers could be given 2 days prior, because they help to relax the outlet, and then we can visualize.
But why you want to do VCUG and RUG? Why not only RUG?
We want to analyze the proximal and the distal limit of the injury, so that this will help for the reconstruction. And also there is, if there is involved the status of the bladder neck. So better delineation of the posterior urethra is on the VCUGs.
Suppose if you're not getting your information, then how to get information?
So as the
What are the
patient
different
is right
ways of
now,
getting that information?
so if the patient here, there is no implant, so then MRI would be ideal. So MRI, we can do a gapometry index and then calculate the defect. If not, then up and downogram or up and down scopy we can do, or bougigram, or even if there is, so MRI would be ideal for this case. T1, T2 weighted MR.
Okay. Gite sir, if you can just.
Yes,
Yeah.
routinely, majority of the center does RUG and VCUG. Why it is done in one go? To assess, because both have two different reasons. RUG is for the anatomical assessment, and some VCUG is anatomical plus functional assessment. RUG का पहला देखते हैं. RUG करेक्ट पोजीशन उसने परफेक्टली बता दिया है. दूसरा बात यह है कि पेनाइल स्ट्रेच कितना करना है, सीवियर स्ट्रेच करना है या मॉडरेट स्ट्रेच करना है या स्ट्रेच नहीं करना है, और स्ट्रेच करना है तो क्यों करना है. तो म्यूकोजल फोल्ड्स एंड जो यूरेथ्राइज एस एंगल है, जो एस शेप्ड है, तो उसका स्ट्रेटनिंग करना एक वन इंडिकेशन. अनदर इज म्यूकोजल फोल्ड्स को भी फ्लैट बनाना है, सो दैट कि इट शुड नॉट मिमिक लाइक अ स्ट्रिक्चर और रिंग ऑफ द स्ट्रिक्चर. सो मॉडरेट प्रेशर देना है, नंबर वन. शेडो स्ट्रिक्चर्स बहुत बार दिखते हैं, जैसा कि कॉब्स कॉलर है, मुरमन्स रिंग है. ये जो बल्बार जो यूरेथ्रा में जो बल्ब के जो मसल्स है, उसके कॉन्स्ट्रक्शन की या स्पाजम की वजह से बहुत बार इंडेंटेशंस होता है वो यूरेथ्रा के ऊपर, and it looks like a stricture. So these are some causes of pseudo strictures. RUG में कॉन्ट्रास्ट इंट्राहोसेशन एंड एक्स्ट्राहोसेशन, ये बहुत बार कभी कभी पूछा जा सकता है. तो फोर्सफुली अगर कॉन्ट्रास्ट दिया है या फिर इन्फेक्शन है एसोसिएटेड, तो इंट्रा या एक्स्ट्राहोसेशन का चांस रहता है, और उसमें बहुत बार ग्लैंड्स एंड वेन्स विजुलाइज हो जाते हैं, पैराऑर्थल वेन्स. तो RUG में अगर कॉन्ट्रास्ट ब्लैडर में जा रहा है, तो एग्जैक्टली RUG is only made for the anterior urethra, not for the posterior urethra, like prostatic urethra, membranous urethra, and bladder. One should not comment on RUG. If it is contrast is going, you just tell कि contrast is reaching to the bladder. VCUG में VCUG ब्लैडर कैसा फिल करना है, तो सुप्रापिविक कैथेटर है तो सुप्रापिविक कैथेटर से करो, पेरियोथल कैथेटर है तो पेरियोथल कैथेटर, फीडिंग ट्यूब अगर जा रहे हो तो फीडिंग ट्यूब से करो, या फिर आईवी कॉन्ट्रास्ट देके डिलेड सिस्टोग्राफी या डिलेड थोड़ा कुछ टाइम रोकने के बाद में कर सकते हैं, या फिर आईवी फ्लूइड लगा के भी ब्लैडर फुल कर सकते हैं आईवी कॉन्ट्रास्ट के साथ. तो VCUG एंड RUG दोनों का जो एक साथ करने का पर्पज ये है कि लेंथ कितना है. तो लेंथ कैसा गिनना है तो एक तो तुम 1 सेंटीमीटर का कोई मेटेलिक अलोंग द यूरेथ्रा रखो और उसके हिसाब से तुम काउंट कर सकते हैं लेंथ कितना है। दूसरा है कि इंफीरियर प्यूबिक रामा का जो ये है विड्थ है वो 2 सेंटीमीटर है, तो उसके हिसाब से भी अपन उसका लेंथ गिन सकते हैं। दूसरा अप एंड डाउन स्कोपी या बुजियोग्राम जो लड़के ने बताया है वो भी एक वन ऑफ द वे कि हाउ मच डिस्टेंस दोनों के बीच में सीएम के अंडर अपन बहुत बार असेस कर सकते हैं। तीसरा है एमआरआई। तो एमआरआई इज नॉट रूटीनली डन इन मेजोरिटी ऑफ द टाइम, इट इज ओनली फॉर टू असेस द कॉम्प्लेक्स स्ट्रक्चर्स, करेक्ट। सो रूटीनली हर चीज में हमारा करने का जरूरी नहीं है। हमारे का बेनिफिट ये है कि एग्जैक्ट गैप कितना है उसको इंफीरियर प्यूबर्टा में लगेगा नहीं लगेगा इसका भी ट्यूटूवेटेड इमेजेस में अगर लिया तुमने ऑब्लिक इमेजेस लिया तो उसमें अंदाजा आ सकता है। अगर पोस्ट यूरेथ्रा इंफीरियर प्यूबिक रामा के नीचे तक आ रहा है तो शायद प्यूबर्टा में नहीं लगेगा, उसके ऊपर है तो प्यूबर्टा में लगेगा। इसमें क्या बेनिफिट है तो पोस्टर एंड ऑफ द यूरेथ्रा एज वेल एज एंटीरियर एंड ऑफ द एंटीरियर एंड पोस्टर एंड एक अलाइन में है या नहीं है। बहुत बार क्या होता है कि एक एंड एंटीरियर सुपीरियर जो ये सॉरी सिंपासिस प्यूबिस की तरफ चिपक जाता है, दूसरा रेक्टम की तरफ जाता है, मिस अलाइन रहता है, तो वो मिस अलाइन का डायरेक्शन हमको पता हो जाता है और हाउ मच इट इज क्लोज टू द डॉर्सल वेनस कॉम्प्लेक्स और क्लोज टू द रेक्टम, उसका भी एक एडिशनल बेनिफिट अपन एमआरआई में असेस कर सकते हैं। तो तीन चीजें हैं, अलाइनमेंट ऑफ द यूरेथ्रा, देन द रिलेशन टू द रेक्टम एंड नीड ऑफ द प्यूबर्टमी। These are the three things can be assessed by the MRI and उसमें गैपोमेट्री इंडेक्स के साथ अपन उसका लेंथ भी असेस कर सकते हैं। तो ये सब चीजें क्यों करना है इन्वेस्टिगेशन, तो फिर एक बार वही पॉइंट पे मैं आ जाऊंगा कि साइट कहाँ है, नंबर कितना है, उसका लेंथ कितना है, लुमेन पर पेटेंट है नहीं है, और उसके हिसाब से फिर प्लानिंग करना पड़ेगा अपने को उसका ट्रीटमेंट का। सो उसके साथ में अगर अप एंड डाउन स्कोपी बहुत बार बहुत सारे लोग करते हैं, उसमें क्या देखना है तो एग्जैक्टली कहाँ स्ट्रक्चर शुरू होता है, वो जो म्यूकोजा का कलर पिंक है या फिर व्हाइट हो गया है, आजू बाजू में बहुत सारे रिंग्स है। बहुत बार क्या होता है रेडियोलॉजी में एक ही जगह पे नारोइंग दिखती है, जब स्कोपी करते हैं तो सडन जस्ट ये संडे को ही मैंने एक केस किया तो मियाटस जस्ट इट्स आर यूज इज लुकिंग लाइक ओनली मियाटस एंड ग्लास जैसा, थोड़ा सा डायलेट करके छोटे स्कोप पेडाइटिस्कोप या यूरोटोस्कोप से स्कोपी किया तो उसका मल्टीपल रिंग्स राइट अप टू द प्रॉक्सिमल पेनाइल यूरेथ्रा, तो जो 2 सेंटीमीटर का बीएमजी लगने वाला था वो 8 सेंटीमीटर का लगना। तो ये सब चीजें स्कोपी में एडिशनल बेनिफिट बहुत बार स्कोपी का होता है। तो स्कोपी इज आल्सो वन ऑफ द पार्ट ऑफ असेसमेंट ऑफ द स्ट्रक्चर यूरेथ्रा बिफोर प्लानिंग एज वेल एज इन बिटवीन स्कोपी भी अगर पोस्टीरियर डिस्ट्रैक्शन डिफेक्ट अगर कर रहे हैं तो इन बिटवीन स्कोपी का भी देयर इज रोल। सो ये आरयूजी और वीसीयूजी के बारे में चीजें है। और कुछ सर बताना चाहते हो तो बता दो आप आपकी तरफ से।
Yeah, so what are the other investigations? Nakul, can you just tell me and the importance apart from this? Siddhant, you can tell us.
Sir, VCUG, MCUG, MR urethrogram. Then, sir, there is also a role of doing CT, contrast CT, with instilling the bladder with contrast and then seeing it with CT and taking 3D printing images. That can also be done.
Usually we have started that technique at JJ Hospital. Whenever it is not possible to do a MRI, then we used to fill the bladder with the contrast as well as fill the urethra with the again contrast and take the non-contrast CT scan with 3D reconstruction. तो दैट विल हेल्प लाइक डूइंग एमआरआई ओनली। बीच में एग्जैक्टली कितना स्ट्रक्चर्स है, कुछ 20-25 केसेस मैं जब तक था तब तक किए थे एंड आई फील दैट इज हेल्पफुल। और 3D प्रिंटिंग का भी अगेन देयर इज इमर्जिंग रोल इन मैनेजमेंट ऑफ द डायग्नोसिस ऑफ द स्ट्रक्चर यूरेथ्रा। वन मोर इन्वेस्टिगेशन समटाइम्स एग्जामिनर में आस्क इज लाइक सोनो यूरोथ्रोग्राफी।
I wanted to ask that.
तो वो एक इन्वेस्टिगेशन है, उसका रोल रूटीनली बहुत बार सोनो यूरोथ्रोग्राफी कोई करता नहीं है, कोई सेंटर पे होता नहीं है। Specifically, the sonourothrography is made to assess the amount of spongiofibrosis and its role is in the urethra where there is a spongiosa. जैसे कि बल्बार यूरेथ्रा में उसका अच्छा खासा रोल है, स्पॉन्जियोफाइब्रोसिस कितना है वो पता करने के लिए। स्पॉन्जियोफाइब्रोसिस अगर ज़्यादा है तो ट्रीटमेंट प्लान डेफिनेटली चेंज हो जाता है। स्पॉन्जियोफाइब्रोसिस अगर छोटा है, अगर स्ट्रिक्चर छोटा है तो उसके लिए वो भी प्लान अलग है। तो स्ट्रिक्चर क्या है, स्ट्रिक्चर डिसीज क्या है, ये सब चीज़ें भी आपको एग्जाम में पूछी जा सकती है। स्ट्रिक्चर मतलब इफ इट इज फोकल शॉर्ट सेगमेंटल है तो स्ट्रिक्चर है, लॉन्ग लेंथ है तो स्ट्रिक्चर डिसीज है। मेम्बरनस यूरेथ्रा में कभी भी स्ट्रिक्चर होता नहीं है, वहाँ स्पॉन्जियोजा रहता ही नहीं है, तो दैट इज स्टेनोसिस।
Stenosis.
ये सब चीजें आपके बीच में एग्जाम में अगर पूछी तो एटलीस्ट ये पता रहना चाहिए।
Fine. So just show them. Rahul, RUG दिखाओ. Yes, Samit, Siddhant,
Yes, sir.
any one of you? Yes, Samit, tell us.
So there is no scout film. So the first film is an RUG where the the contrast is opacifying the penile urethra up to the penile, and beyond that the contrast is not we cannot visualize the distal the part of the proximal with the mid and the distal vulvar along with the posterior urethra, along with the evidence of fracture where there is the superior inferior pubic rami fractures with bony fragments and spicules are seen. And on the second image is the image of the VCOG of the filling where the bladder is adequately filled, and where the bladder neck is appears to be open, and beyond that we cannot see the contrast entering the posterior urethra.
Prostatic
Up to what level it is entering?
is
So to the just prostatic.
Yes.
So, till the level of the prostatic urethra, till the level
Yes,
of the membranous urethra is not opacified, but
opacified, yes.
urethra is opacified.
See properly and tell me whether it is going distal to verumontanum or not.
It is just
I
going
think-
and ending just beyond the Veru.
Just beyond.
Yes, a willing, yes, sir.
Very tiny.
The left, the second from above, and the left hand side, the first out of 4. Just see till what level it is going. Isn't it going distal to verumontanum?
Yes, sir. Now in the downfield.
Correct?
Yes.
It is
Okay.
going to the membranous.
Fine. So now, any other test you would like to do, or you want to go ahead with the management?
Here then penile Doppler, sir.
Okay, very good. Show them penile Doppler.
This was the USG of the patient.
So all of you missed this ultrasonography also, huh? Because you like to know about the status of kidney, ureter, and then otherwise, any other intra-abdominal anomaly if it is there.
Yes.
Or abnormality. Correct? So always talk about ultrasonography. Yes, show them color Doppler. Yeah, show them the result.
Yes, sir.
Okay, so normal
No.
vasculogenic response is seen following papaverine injection. So, Siddhant, now how will you go about? Think properly and answer now.
Non-vasculogenic response. Sir, as the peak after giving injection papaverine, the peak systolic velocity have increased more than 10. So it is normal, sir. And
No, it is okay. Fine, fine. So it is showing a normal vasculogenic response.
yes, sir.
Correct. Now, how you are going to manage what you will tell the patient? So how you are going to manage this?
So first, I would like to counsel the patient regarding. I will counsel the patient regarding the disease process that he is having a distraction defect. So it will require a definitive management. So I would like to tell that he would require anastomotic progressive perineal urethroplasty. And I would also like to tell him that after the surgery, I would also like to explain him the complications of it, as he's a young man, that after doing such surgeries, there might be a chance that patient might develop erectile dysfunction post-operatively. So I would like to tell him that also, and then, sir, go ahead with the surgery, sir.
So then I would also explaining about the anesthesia and then the success rate of the surgery, that it could the almost 85 to 90, more 90% success rate is there, and then the need for regular follow-ups post and the advices needs to be followed properly. So that needs to be also explained.
Okay. Fine. So how will you go about? What surgery? What are the steps?
The first,
What will be the plan A, B, C, D, E?
so the
If first plan is not successful, then what else you'll do?
So first, I
Here
would like to
will
go for progressive. First place the do basic investigations, cross match the blood, because keep blood reserved. Then put the patient under general anesthesia, extended lithotomy position. Take a midline perineal incision just from the penoscrotal angle to 1 centimeter above the anal verge. Then dissect, come towards the bulbospongius muscle and cut it from the and dissect it and separate it. And then, sir, after we would like to put a catheter from below to look for the distal margin of the stricture. And we need to excise the stricturous part. We can put a Hebrew dilator from the SPC side to look for the proximal margin. If the proximal margin is visible, we would like to dissect in that area after circumferentially mobilizing the bulbar urethra and excising the stricturous part. If the proximal urethra is visible, then is visible by the Hebrew dilator, I would like to dissect on that. If it is not visible, then I would like to go ahead and do more mobilization by doing a crural separation. Or if there is any need, if there is any presence of any callus, as it was shown in the X-ray, I would like to remove the callus, remove the fibrotic tissue, and by doing an inferior pubotomy. Or if that is also not possible, the fourth last option would be supracrural rerouting. And after that, if we can get the proximal urethra after adequate mobilization, it should overlap up to 1 centimeter, and then we'll do a spatulated anastomosis. We'll do dorsal spatulation on the proximal ureter and ventral spatulation on the distal ureter, and then, sir, go ahead with the anastomosis after placing the catheter.
Suppose if the length is not adequate, now what you'll do?
So then we can go ahead with the abdominoperineal approach or a transpubic urethroplasty.
Okay. And if it is already redo surgery, then?
Sir, then we can use penile flaps or penile vascularized or tubularized flaps, which can be transposed from the penile invaginated into the scrotum, tubularize it over the Foley's catheter and anastomate it with the proximal and the distal end.
So what are the causes for failure?
Causes of failure, sir, it could be because the anastomosis would be under tension. Or the anastomosis could be with a false passage, because in some cases there would be false passage in the proximal urethra, so anastomosis can be there. Then, sir, excessive bleeding could be the cause. Excessive bleeding can be a complication. Then post-operative, sir, infection. Then a post-operative patient is under lithotomy position over a long period of time. So positional complications such as injury to the superficial peroneal nerve, that, and long-term complication could be a presence of an anastomotic stricture, or a patient may present with erectile dysfunction. Sir.
Oh, my question was, what are the causes of failure?
So
The main
One,
tension is too tight tension, no, and then there may be evidence of the leak. Along with that, there is intraoperative bleeding. The callus and all the fibrotic tissues has not been cleared off properly, and the anastomosis with the false passage, with not proper visualization. So, like, the proper mobilization of the two margins has not been achieved. So that can result into a failure or a restricture.
as well as the
and
patient factor being anemia, then other cofactors also like malnutrition, other comorbidities like LFT derangement also that can play a role in failure of the surgery also.
during operation, one most important thing your people are forgetting.
So there is also injury to the blood vessels like ischemia,
Exactly. That is the most bulbar.
bulbar vessels. We can spare one side, but if both side uh, like injury, so there may be bulbar necrosis.
So, Samit, tell us why you can, one side is okay, but both sides are not okay.
So because of the
What is the anatomical reason behind this?
uh, so
Because of the blood
there
supply to
might
the
be
glands comes
blood
from
supply.
the
Yeah, tell me. Omar, you know?
Sir, not actually.
Siddhant?
Yes, sir. So I didn't get the question, sir. Sorry, sir.
No, they are saying that at least one side of bulbar artery should be preserved.
Yes, sir. Sir, circumferential mobilization of bleeding can lead to bulbar urethral necrosis, or it can damage the neurovascular bundle, so can lead to erectile dysfunction.
So, is there something like as a retrograde blood supply also?
the blood supply
Oh,
from the
so
one side goes to the glands and come back
if
from
you
retrograde
know
to
the
the other side.
if you know the blood supply of the penis,
Yes, sir.
it has a dual blood supply, one from below and one from above, and that will circulate across the glands. Correct. So if the dorsal penile artery is good, and if you injure both the bulbar also, there will not be a major problem. If patient is having associated hypospadias, dorsal penile artery injuries, along with insufficiency or ill-developed dorsal penile artery, trauma हो गया है उसको भी, तो फिर ऊपर का भी चला गया, नीचे का भी चला गया, तो फिर प्रॉब्लम होता है. That's why we are planning for penile Doppler prior in such complex cases. Number one. Number two, before planning such type of surgeries, the inflammation, infection, everything should be settled, and the stricture doesn't have active disease. अगर वो एक्टिव है तो तुम्हारा कोई भी सर्जरी करो, किसी के भी हाथ से करो, वो फेल होने वाला है.
Yes.
हाँ, तो इसीलिए बहुत बार जब अर्ली फेज में 3 महीने में ही करेंगे, जल्दी कर देंगे, पेशेंट बोल रहा है बहुत दिन हो गया, ऐसा नहीं है. पेशेंट ब्लैडर का पोजीशन कहाँ पर है, शिफ्ट बाय शिफ्ट पे इसके कितने ऊपर है, क्लॉट डिजॉल्व हो गया कि नहीं हो गया, ब्लैडर सेटल हो गया कि नहीं हो गया. तो कभी कभी 3 से 6 महीने तक भी रुकने में कोई नुकसान नहीं है, कोई और एक गलत आंसर भी नहीं है. मिनिमम 3 months इज ओके. व्हाट यू आर टोल्ड 3 months इज ओके. यू टोल्ड 6 months also, I am also I am fine for that 6 month answer also. It is depend upon the amount of injury and how much it is get settled before going for the surgery. Prior any instrumentation we have कुछ भी नहीं होना चाहिए फर्स्ट लास्ट 3 month में, या कम से कम कि वो एडिशनल ट्रॉमा रहता है. वैसे इसमें भी बहुत बार ये स्ट्रक्चर जो सर्जरी है वो फेल होने का चांस रहता है. फर्स्ट अभी आएगा पोजीशन लिथोटमी, सोशल लिथोटमी पोजीशन है अप्रोक्सीमेटली 5 आवर्स से अगर कम लगने वाला टाइम है तो सोशल लिथोटमी से काम बनने वाला है. एक्सटेंडेड लिथोटमी इज अनदर पोजीशन, इट इज डिपेंड अपॉन द इंस्टीट्यूशनल प्रोटोकॉल. नंबर 2, इंसिजन लेना. इंसिजन लेने के बाद में जो प्रोग्रेसिव पेरिनियल यूरेथ्रोप्लास्टी के कुछ फिक्स कंपोनेंट है, वो कंपोनेंट तुमको पार्ट रहना चाहिए, याद रहना चाहिए. जैसा ये कि बट जो भी जिसने भी बताया है वो परफेक्ट बताया है कि समझो पहले तो मोबिलाइजेशन करना है. मोबिलाइजेशन कैसा करना है, कैसा कंफर्म करना है पेनोस्क्रोटल जंक्शन तक पहुंचा कि नहीं पहुंचा तो अंदर से उंगली रखो, पेनोस्क्रोटल जंक्शन से बाहर से उंगली रखो और फिर देखो कि वहां पूरा मोबिलाइज हुआ है कि नहीं है. उससे ज्यादा मोबिलाइज किया तो क्या प्रॉब्लम होने वाला है, तो क्वार्डी होने वाली है, अनास्टोमोसिस टेंशन में आने वाला है. तो इसलिए वो उससे ज्यादा ये अपना जो मोबिलाइजेशन नहीं कर सकते. दूसरा है कार्पोरल स्प्लिटिंग है. तीसरा बात है कि रीरूटिंग है, जो प्यूवाटॉमी है, इन्फीरियर प्यूवाटॉमी लगेगा नहीं लगेगा प्री ऑपरेटिवली अपन एमआरआई से असेस कर सकते हैं. इन्फीरियर प्यूवाटॉमी करने के बाद में अगर नहीं होगा तो रीरूटिंग, और उससे भी नहीं होगा तो अब्डोमिनोपेरिनियल अप्रोच से दोनों तरफ से करना है. उससे भी नहीं बना तो ट्रांसप्यूबिक करना है. तो ऐसा भी अब्डोमिनोपेरिनियल या फिर ट्रांसप्यूबिक जो भी लास्ट के दो है उसमें बहुत बार बड़ी कैविटी रहती है तो उसमें मोमेंटम लगाना पड़ेगा, वो कैविटी को फुलफिल करना पड़ेगा. ये सब चीजें उसके साथ भी आपको आना पड़ेगी. इंफीरियर प्यूबोटॉमी करते समय पूरा जो पेरियोस्टियम इलिवेट करके अंदर से इंफीरियर प्यूबोटॉमी करना है कि दलेला साहब के जैसा पूरा ऑल अराउंड इंफीरियर प्यूबोटॉमी करना है, तो कुलकर्णी सर जैसा बोलते हैं वैसा ही करना है. एक्चुअली जो सिंपल जो उसका पेरियोस्टियम उसको इलिवेट करके वेसल को बाजू में करके ही इंफीरियर प्यूबोटॉमी करना है. दैट इज एटलीस्ट एक थंब के इतना अपना रहना चाहिए कि वो करना इसीलिए है क्योंकि वो अनास्टोमोसिस ईजी होना चाहिए, सुचर लेने को बेनिफिट होना चाहिए. दूसरा बात है कि पोस्टीरियर एंड अभी कैसा कैसा आइडेंटिफाई करना है. ये वन मेथड इज ये अपना जो हिगुरु डाल के पालपेट करो. हिगुरु पालपेट बहुत बार होता नहीं है, तो फिर ऐसे सिचुएशन में क्या करेंगे, तो ऊपर से स्कोप डाल सकते हैं, फ्लेक्सिबल स्कोप, नॉर्मल स्कोप. रिजिड स्कोप बहुत बार हीरो के नीचे आता नहीं, तो फ्लेक्सिबल स्कोप उसके लाइट के अगेंस्ट कट कर सकते हैं. लेकिन कोई भी ऐसा सर्जन नहीं रहेगा कि वो फ्लेक्सिबल के ऊपर ब्लेड से कट करेगा, उसको फ्लेक्सिबल खराब हो सकता है. दैट इज लेकिन वन ऑफ द मेथड के वो डायरेक्शन कौन से डायरेक्शन में कट करना है. तीसरा मेथड है होशनिज मेथड, जिससे निडल डालते हैं उसमें से वायर डाल के वो वायर के ऊपर फिर और वो निडल के ऊपर कट करना पड़ता है. तो दीज आर द वेज फॉर आइडेंटिफाइंग द पोस्टीरियर. कितना पूरा सबसे इम्पोर्टेंट अगर चीज क्या है तो वो है कि वो जो स्पॉन्जियोफाइब्रोसिस है वो पूरा एक्सरसाइज नहीं किया. मेजॉरिटी पीपल व्हाई गेटिंग द रिकरेंसेस इज वरीड अबाउट द कंप्लीट एक्सीजन. मतलब वो डर के मारे करते नहीं, थोड़ा सा निकाल देते फिर जैसा भी दिख गया कि अनास्टोमोसिस कर देते, उसमें पक्का उसका रिकरेंस होने का चांस रहता है. तो कंप्लीट एक्सीजन ऑफ द स्पॉन्जियोफाइब्रोसिस इज वेरी मच नेसेसरी. एंड वो कैसा पता करना है, तो ऑल अराउंड जैसा तुम किसी के ऊपर भी अगर फिंगर रखे तो पता चलता है कि वो हार्ड है कि सॉफ्ट. म्यूकोजा प्रोलैप्स होके जो प्रॉक्सिमल यूरेथ्रा का म्यूकोजा प्रोलैप्स होके बाहर आना चाहिए, दिखना चाहिए कि वो क्लियर कट आजू बाजू से कोई भी स्पॉन्जियोफाइब्रोसिस नहीं है. ब्लीडिंग दोनों एंड से होना चाहिए, वो भी एक बहुत इंपॉर्टेंट चीज है. कट कर दिया है, ब्लीडिंग नहीं हो रही है, वैसा ही अनास्टोमोसिस कर दिया तो उसमें भी फिर फेल होने का चांस. तो अनास्टोमोसिस शुड बी मुझे मतलब एक्सीजन ऑफ द स्पॉन्जियोफाइब्रोसिस जो है वो कंप्लीट रहना चाहिए. टेंशनलेस अनास्टोमोसिस रहना चाहिए. कितना यूरेथ्रा में एटलीस्ट 1 सेंटीमीटर ओवरलैपिंग हो जाना चाहिए एक के ऊपर एक. ये अगर तुम यूरेथ्रा मोबिलाइज कर रहे हैं तो उसका 1 सेंटीमीटर आगे गया तो वो टेंशनलेस रहेगा. और फिर अनास्टोमोसिस को फिर डॉर्सल वेंट्रल स्पैचुलेशन, वेंट्रल वेंट्रल स्पैचुलेशन, कैसा भी स्पैचुलेशन करो कुछ फर्क नहीं पड़ता. 3-4 मेथड है, तुमको जो रूटीनली वहां पे करते हो करो. आप सुचर्स कैसे भी लो, बाहर से सुचर करना, बाहर से रखो अंदर से रखो, उससे भी कुछ फर्क नहीं. फिर वो उसके बाद में आएगा कि वो कैथेटर कौन सा डालना है, साइज का कौन सा डालना है. तो ऑलवेज ट्राई टू प्लेस द स्मॉलर साइज ऑफ द कैथेटर, बिकॉज उसके ऑल अराउंड जो भी सिक्रेशन है, क्लॉट्स है, वो सब निकल जाना चाहिए. नहीं तो फिर क्या है, वो पूरा इम्पैक्ट बड़े साइज का कैथेटर यूजुअली 12 to 14 फ्रेंच एडल्ट में यूज करते हैं. अपन छोटे इसमें 8 to 10 फ्रेंच यूज, पेडियाट्रिक में 8 to 10 फ्रेंच यूज करते हैं. एसपीसी तो यूरोथ्रल रेस्ट का कंसेप्ट है. जहां जहां भी तुमको डाउट लगेगा वहां यूरोथ्रल को रेस्ट देना ही देना है. उसके बजाय जो ये है क्या बोलते हैं उसको, इन्फ्लामेशन इन्फेक्शन, वो कम नहीं होगा. लेकिन यूरेथ्रल रेस्ट का कंसेप्ट को दोनों तरफ से डिफेंड किया जा सकता है. एग्जाम में अगर एग्जामिनर को लगता है कि यूरेथ्रल रेस्ट लेना जरूरी नहीं, अगर उसका एटीट्यूड वैसा लग रहा है तो ठीक है, नहीं जरूरी तो नहीं है, लेकिन अगर लेने के लिए यूरेथ्रल रेस्ट देना जरूरी है, ये डिपेंड करना इजी है तुम्हारे लेवल पे, क्योंकि वो फिर पूरा ब्लैडर को रेस्ट हो जाती है, यूरेथ्रा को रेस्ट हो जाती है, डाइवर्ट हो जाता है वो यूरिन, पेशेंट इज नॉट पासिंग द यूरिन अगेंस्ट द रेजिस्टेंस, तो इंट्रावसेशन नहीं होगा, पेरीयूरेथ्राइटिस नहीं होगा, स्पॉन्जियोफाइब्रोसिस नहीं बढ़ेगा, इसलिए वो सब इन्फ्लामेशन कम होगा, इन्फेक्शन कम होगा, उसकी वजह से हम यूरेथ्रल रेस्ट दे रहे हैं, ऐसा बताया तो कोई रॉन्ग उसको बोलने वाला नहीं। अनास्टोमोसिस के बाद में एसपीसिया और पेरियोथल कैथेटर, ये दोनों चीजें रखना है। पेरियोथल कैथेटर कब कब निकालना है, पेरी कैथेटर स्टडी करना है कि नहीं करना है। मैक्सिमम 6 हफ्ते से ज्यादा कोई भी पेरियोथल कैथेटर रखने में कोई वैल्यू नहीं है। मैं एट द मैक्स इट इज 6 वीक। आंसर, आइडियल आंसर इज 4 वीक। पेरियोथल पेरी कैथेटर स्टडी सेलेक्टेड पेशेंट में डेफिनेटली करना है, जो भी कॉम्प्लेक्स टिक्चर के लिए किया है, टेंशन में लगता है तुमको अनास्टोमोसिस, ऐसे सिचुएशन में अपन पेरी कैथेटर स्टडी करते हैं। कैथेटर पेरी कैथेटर स्टडी करने के बाद में अगर लीक लगा है तो वो वही वायर के ऊपर फिर कैथेटर रखे और 1-2 हफ्ता उसको कैथेटर रख सकते हैं। उस 6 हफ्ते के बाद में तुम जो रिजल्ट है वो तुमको एक्सेप्ट करना पड़ेगा। तो कैथेटर निकालने के बाद में फिर एसपीसी 48 आवर के लिए क्लैम करो, पेरियोथल पास होता है कि नहीं होता है देखो, उसके बाद में कुछ एक्स्ट्रा ओसेशन हो गया, फीवर आ गया, तो फिर एसपीसी ओपन करो, वेट करो, और अगर पास कर रहा है तो फिर आ, उसका सक्सेस, अभी मैं यूजुअली एसपीसी इमीडिएटली निकालता नहीं हूँ, बहुत बार एसपीसी क्लैम करके भेज देता हूँ, 1 महीने के बाद बुलाता हूँ, और फिर उस टाइम पे यूएसजी फॉर पोस्ट वाइड रेशियो, यूरोफ्लोमेट्री, ये सब चीजें करके उसका पोस्ट वाइड कितना है, उसको पास यूरिन पास करते समय कोई तकलीफ हो रही है क्या, ये पूरा क्लिनिकल प्लस सोनोग्राफी प्लस यूरोफ्लोमेट्री, इसका असेसमेंट करके ही डिसाइड करता हूँ कि उसका एसपीसी निकालना कि नहीं निकालना। ओवर कॉन्जर्वेटिव है लेकिन ऐसा करे तो कोई नुकसान नहीं, फिर उसके बाद में एसपीसी निकाल देना है और फिर फॉलो अप। तो इसमें अगर कोई किसी को कंफ्यूजन है तो बता दो। अब दो एक बात भूल गया,
सर, आपने आपने बहुत
इंट्राऑपरेटिव
ब्यूटीफुल
एंडोस्कोप,
समझा, आपने बहुत ब्यूटीफुल
इंट्राऑपरेटिव
समझाया। खाली दो ही चीज है, आई वांट टू आस्क देम that what suture material they will use and how they will take the sutures.
सर,
30Y.
वन मोर पॉइंट आई बिफोर आई फॉरगॉट, इंट्राप एंडोस्कोपी बिल्कुल बताना है। अगर
Yes.
उसमें कोई नुकसान नहीं है, इंट्राप एंडोस्कोपी करना बहुत जरूरी है। गलती से वो लेस देन 1% इसमें ही अबनॉर्मल ट्रैक को अनास्टोमोसिस होता है, लेकिन वो उसका रेडो सर्जरी करना बहुत मुश्किल हो जाता है। तो 1-5 मिनट के लिए इंट्राप एंडोस्कोपी करके कंफर्म करने में कोई नुकसान नहीं है, बिकॉज तुम्हारे जो भी फाइंडिंग्स है इंट्राप एंडोस्कोपी के, वो ब्लैडर के फाइंडिंग्स रहो, पोस्टीरियर था का रहो, उसका तुम्हारा जो एक्सीजन हुआ है स्पॉन्जियोफाइब्रोसिस का वो कंप्लीट हुआ है कि नहीं हुआ है, यूरो से कितना डिस्टल एनास्टोमोसिस है, स्फिंक्टर का क्या सिचुएशन है, बहुत सारी चीजें इंट्राप एंडोस्कोपी से अपने को पता चलते, अलॉन्ग विथ फॉल्स पैसेज को एनास्टोमोसिस हो रहा है कि नहीं हो रहा है इसका भी पता चलता।
Yeah. So yes, that cystoscopy for the posterior, I mean proximal urethra is must. It is very important. And yes, you said, Samit, that you will take 30 stitches,
Like,
Vicryl,
yes, sir.
correct? But how will you
Yes,
take it?
sir. At our institute, sir, we take at 6 places, sir. At 11, 1, 3, 5, 7, and 9 o'clock.
Okay. And
And
you take all the
then,
stitches?
no, sir. We usually number them, and first we do the posterior, like at 5 o'clock, 7 o'clock, and then insert the catheter, and then the remaining over the catheter. Then.
And you mark out the
So usually
this
we
thing.
use a Turner Warwick, the ring retractor, sir. So we can align as per the uh, direction, sir, or we use alternate straight or curved artery forceps,
Mosquitoes. Okay,
mosquitoes.
artificial. Yeah. So these are the odd. Some people mark out, like, left, on one side they use a curved and on another side they use a straight, and they mark it out like a 1, 2, and 3, 1, 2, and 3. So they know it, they're what they are going to stitch. The important thing is that dorsal side you take the stitches, ventral side one stitch that you should take it last, so that when you are inserting catheter, okay, that vicryl will not entangle the catheter. Otherwise, you may have difficulty in removing the catheter on, uh, tying. There may be a fistula later on. So that is very important. Correct. Fine. Vinod bhai, any comment from you? Any question you want to ask? Dr. Vinod Joshi. पंकज
सर
भाई.
आपका ऑडियो बंद है.
Yeah, now it is on. Now I could learn a lot of things, Dr. Gite, from you. The only kind of a thing which I did not understand is about scopy, which you mentioned. I never used to do a scopy. Now you mean to say that scopy is to be done before the sutures? Is that right?
Yes, yes,
Yes.
Especially to
Yes.
see posterior urethra, because that is a
yes. It is only important indication for in my practice is to avoid the anastomosis to the wrong track.
right. That scopy I do.
Again, for the students, particularly कितना मोबिलाइजेशन करना है. 1 सेंटीमीटर स्ट्रक्चर के लिए एटलीस्ट मिनिमम 4 सेंटीमीटर का मोबिलाइजेशन करना पड़ता है. और हर स्टेप में वेबस्टर का जो एलाबोरेटेड अप्रोच है उसमें हर स्टेप में कितना सेंटीमीटर का बेनिफिट होता है ये भी तुमको पता रहना चाहिए. जैसा बल्बार urethra अगर पूरा मोबिलाइज कर दे तो 5 to 6 सेंटीमीटर का गैप ब्रिज हो जाता है. तो हर स्टेप का वो लेंथ भी आपको याद रहना जरूरी है.
Yeah. Fine. Pankaj bhai, you want to ask any question or then we can go ahead with one more case?
Please go ahead, sir.
सर उसमें सक्सेस ऑफ स्ट्रक्चर ट्रीटमेंट एक क्वेश्चन लास्ट में पूछा जा सकता है कि व्हाट इज कॉल्ड एज सक्सेस ऑफ द स्ट्रक्चर ट्रीटमेंट.
Yeah, who is going to answer?
So the flow rate should be more than 15. IPSS score should be improved, usually less than 10. The radiographic study, the RUG, VCUG should be normal, and patient should have no evidence of any infection and should be stable.
And insignificant PVR.
So patient should not require any further instrumentation or dilatation.
Yes, asymptomatic, more than 15 ml. Radiologically, both investigation RUG as well as MCUG normal. Urine culture is sterile. दैट इज द एंड फॉलो अप में भी फिर तुमको बेसिकली जब भी तुम फॉलो अप करते हो तो इट इज 3 मंथली और अभी कुछ चेंज हो गया होगा तो पता नहीं, लेकिन 3 मंथली फॉर 2 ईयर, 1 ईयरली फॉर 5 ईयर एंड ईयरली फॉर एटलीस्ट 15 ईयर फॉर सब्सटीट्यूशन ऑर्थोप्लास्टी. 5 साल अनास्टोमोटिक के लिए, सब्सटीट्यूशन के लिए कम से कम 15 साल, और फर्स्ट 2 साल में 3 महीना करना, 3 माह एवरी 3 मंथ को करना है, क्योंकि डिलेड रिकरेंस ऑफ द स्ट्रक्चर्स आर मोर कॉमन इन केस ऑफ द सब्सटीट्यूशन ऑर्थोप्लास्टी. सो उसमें फिर नॉन इन्वेजिव फॉलोअप एंड इन्वेजिव फॉलोअप है. नॉन इन्वेजिव फॉलोअप में क्लिनिकल एग्जामिनेशन, हिस्ट्री, आईपीपीएस स्कोर, यूरोफ्लोमेट्री एंड सोनोग्राफी, दैट इज नॉन इन्वेजिव फॉलोअप. इन्वेजिव फॉलोअप में फिर तुमको जो रेडियोलॉजिकल इन्वेस्टिगेशन है वो करना पड़ेगा या फिर स्कोपी करना पड़ेंगे. दैट्स ऑल.
Sir, so every 3 monthly, these all investigations are to be done.
एवरी 3
Non-invasive.
मंथ. नहीं, सिम्टोमेटिक है तो आगे बढ़ना है ना. अब तुमको
Yeah.
तो नॉन इन्वेजिव को तो कुछ नहीं करना है ना, ओपीडी में बैठे बैठे सब कर लेंगे ना. हिस्ट्री पूछने में क्या लगता है, आईपीपीएस स्कोर को क्या लगता है, यूरोफ्लोमेट्री करने को क्या लगता है.
So someone has asked what is the difference between substitution and augmentation uretroplasty?
सर ये तो बड़ा सादा सवाल है. सब्सटीट्यूशन मतलब मैं आपको सब्सटीट्यूट कर रहा हूँ,
Yes.
और ऑगमेंटेशन मतलब मैं आपको
You
सपोर्ट
are
कर रहा हूँ.
adding. Yes. So it is very clear. Fine. Okay. So then we have got another case. We finish that. Rahul.
Yes, sir. A 25-year male presented with poor urinary stream for 2 months, straining during micturition for 2 months, increased frequency of urination for 1 month, burning micturition since 4 days, and fever since 3 days.
So we will go very fast in this case. Samit,
Yes, sir.
so what are the important things you want to know? And then
So
we'll
the
go ahead.
onset, duration, progression of the symptomatology. So wanted to ask about the poor stream. Then any associated other symptoms which are present. Elaborate about the symptoms, that is straining and frequency, how much frequency is having, and then history of any lithuria, hematuria, dysuria, any and then also ask about the fever history, whether the fever was continuous or intermittent, whether there was any diurnal variation, whether it relieved on any antipyretics or not, and then also about the negative history, that like lithuria, hematuria, abdominal pain, discomfort, any history of scrotal swelling, or any history of history pertaining to like epididymoarthritis or prostatitis, then any history of perurethral discharge or sexual contact with an unprotected sexual intercourse, and then history of any retention episodes or near retention, and then after that history pertaining to the renal failure symptoms like pedal edema, puffiness, dyspnea on exertion, and any history of interventions or any catheterization, surgical history in the past, any trauma history to the past or to the back, or any other symptom, and also stratify the IPSS score based on the symptoms. So predominantly here is having mixed, but predominantly there is avoiding symptoms more than the storage.
Rahul, just show them the history and go ahead.
Yes, sir. The patient was apparently well 3 months back when he started noticing a gradual decrease in urinary stream, which was initially mild but progressively worsened. The stream became thin, weak, and prolonged, associated with straining during micturition. He gradually developed increased urinary frequency, sensation of incomplete bladder emptying, post-void dribbling. Patient reports significant difficulty in voiding now. Since last 4 days, he has developed burning micturition, persistent and worsening, low-grade fever, intermittent, relief partially with medication, and mild suprapubic discomfort.
Go ahead.
Patient had redness over glans penis with pus discharge and inability to retract foreskin associated with dysuria and burning. He and he had underwent circumcision and cystoscopy 4 months back. Patient is sexually active.
Yeah, just go ahead. Just show them all the
Yes, sir.
investigation. I mean, examination and then investigation, and then we'll go on a management.
Yes, sir. No history of before this. No history of abdominal flank pain, fever, chills, dysuria, pyuria, hematuria, lithuria, urge incontinence, recurrent urinary tract infections prior, trauma, nausea, vomiting, or similar complaints of prior balanitis or genital ulcer, or similar complaints in partner. Past history as described: cystoscopy with circumcision 4 months back. Habits: he's an occasional drinker, non-smoker, non-tobacco chewer, and his bladder history is disturbed as described. General examination: he is afebrile at present, 97.3 is the temperature. Rest is normal. Inspection of the per abdomen is normal, sir. Palpation is also normal. Per rectal examination is also normal, sir.
Fine. So, Omar, what is your impression after this?
Sir, looking at the history, we conclude that the patient having a history of cystoscopy and instrumentation, as well as having discharge. So there can be patient might be suffering from urethral stricture, which can be either caused due to any infection or due to instrumentation.
Okay. Just show them the investigation.
Anything significant?
No, mild elevation of the liver enzymes, sir.
Okay, fine. Then sonography.
This was the urine routine, sir.
Okay. Go ahead.
Histopathology of prior circumcision is available.
No, sir, it's not available.
Cystoscopy details.
What was the finding of cystoscopy?
Cystoscopy findings were not given by the patient. He just mentioned that he had undergone a circumcision and cystoscopy at a local hospital.
Anyone? Samit, you
Yes, sir.
like to read this?
So this is a ultrasonography of abdomen. Starting from the top, the liver and gallbladder solid organ appears to be normal, and can't see whether the right kidney, so that appears to be normal with normal corticomedullary differentiation without any evidence of hydronephrosis or any hyperechoic focus or any stone, and the bladder appears to be uh, it appears to be filled with normal. So the thickness appears to be normal, and the the prevoid and the so the postvoid image is, and the left kidney also appears to be normal.
Yeah.
The
And post-void residual?
post-void residue is significant, sir.
Yes.
Where and with the volume is not mentioned, but it is significant. It is not emptied properly, and the prostate also appears to be normal.
Show them the report.
The impression says that is changes of cystitis are seen.
Fine. So next, what you want to do?
Uroflowmetry.
Rahul? Yeah.
This is
Yes,
so here
Amit, go ahead.
so patient is voided a volume of 200. Here there is slight hesitancy, along with there is classically the flow pattern is box or a plateau type, where the average flow and the maximum flow is very low, so 5.3 and 2.5, and there is also interruption of the stream, and prolonged voiding is also seen.
So Nakul, now next, what you want to do?
I will plan.
Let's see. What is the post-void residual? It is written above.
200 ml.
279 ml on bladder scan at voided volume of 200 ml.
Yes, sir.
So what you will call this? Acute retention, chronic retention, or normal?
I didn't get the question, sir. Sorry.
So what you, when 279 ml is retaining inside at the voided volume of 200 ml. So this is acute retention, chronic retention, or it is normal?
Consider it chronic retention, sir, in this scenario.
So now tell me, what is the definition?
So more than 300 ml in three different setting within the period of 6 months would be considered as chronic retention, sir. The PVR of
With pain,
300 ml.
without pain?
Painless, sir.
So say that, na? When you are saying any definition, it should be a complete. Fine. So now what you want to do?
considering the flow pattern where it is classically a box type or a plateau type and age of the patient with history which is all pertaining to stricture disease. I would like to, and as the urine routine is also normal, I would like, and the culture is no growth, like to go ahead with RUG, sir.
Okay, Rahul, show them. Omar, can you read it?
Yes, sir. Sir, the in this retrograde ureterogram, we can see that the bony structure of the pelvis is grossly normal. There is no any fracture of any bone. In this, the anterior urethra is appreciated, and the there is
First of all, tell me, is it a norm? It is a properly taken uretrogram?
no, sir. The position is not proper.
Stricture.
The firstly, sir, only one obturator foramen should be seen in the X-ray, and secondly, the urethra should be held in a way that it is parallel to the femur. Both of these things are not seen, and the
And third?
stretch, a little bit stretch over the
Yeah.
penis is to be given, which is not seen in this.
Okay. Then?
Sir, in this, the penile urethra appears grossly normal, and the
What about bulbous urethra?
so bulbar urethra
So
is
there is a
also
total cutoff, na?
cut off beyond the bulbar, sir.
So you think it is a rupture urethra? Is it transected urethra?
Spasm of the sphincter.
Sir, I would need a VCUG to confirm, sir.
So how will you do VCUG in this?
So contrast is not going in this patient, but sir, either by an suprapubic or by a delayed film after giving IV contrast, you can do it.
Any other way you want to delineate a posterior urethra? What you
So
would
by
have done?
alpha blocker we can give and then after that 2 days we can do.
Okay. So now this is a plates you have got. Now what you want to do?
So one more comment. Whenever you comment on a contrast study, always ask for a pilot image. Never comment on any contrast study without a pilot image. And
Yes.
alpha blockers will help only in MCU. It will not help in RGU. So it helps in opening of bladder neck so that the prostatic urethra fills when there is a micturating image. How will alpha blockers help here?
Yes.
So what, Samit, to relax the external sphincter, what you should do?
So then if not, this is not possible, then we can even ask for an autourethrography where the patient instills the contrast by himself so that there is better.
So
Sir,
why you don't want to put a xylocaine jelly?
And jelly. And we can even ask the to strain or to void at that time.
Okay. So anyway, now this is a films. Now what you want to do?
The film is not giving any so here we can go ahead with a office cystoscopy and see the.
This patient is
Siddhant?
voiding, he has no history of retention, and I will give a
No history
general
of
attempt
retention. Just now you said, na, it is a chronic retention.
No, sir, but patient is voiding in his history. He is having straining, but he is voiding. So there is no.
But the flow is poor.
Here the posterior SI is not being seen better in RGU. So I will give a gentle attempt of placing feeding tube to fill the bladder and try to do for the VCUG. If at all I am not able to place the feeding tube at all, then I will plan for diagnostic cystourethropy for the same.
Okay. Gite sir.
Sir, this RUG contrast is going right up to the membranous urethra or bulbomembranous junction. Why contrast is not going inside the bladder? So I feel personally it may be a sphincteric spasm or complete block. Only two differential diagnosis. If it is a sphincteric spasm, okay, if it is complete block, he will be in detention. He will not pass the urine. If it is not complete block, then he will pass the urine with some difficulties. Some if you suppose he has some pelvic floor disorder, dysfunctional voiding, the pelvic floor muscle spasms, या ऐसा कुछ फंक्शनल इश्यूज है तो लोअर वाइडिंग सिम्टम्स पक्का रहेंगे लेकिन लुमेन विल बी मेंटेन. सो ये रूल आउट करने के लिए हमको एक डायग्नोस्टिक स्कोपी करने में इसमें कोई गलत नहीं है, आंसर भी गलत नहीं है.
परफेक्ट.
हाँ, तो अगर वो स्कोपी नॉर्मल है तो नेक्स्ट थिंग इज अपना एरोडायनामिक्स. हाँ.
Okay. Suppose if it is a small stricture, okay, Nakul,
Yes, sir.
then what is the role of VIU or under vision urethrotomy?
Yes, sir. It is the first episode. Patient is young, and if it is a small stricture, then we can definitely give trial of VIU in this setting, sir. So for the first episode, first attempt, it has success rate of around 50%. We will explain the patient regarding the recurrence of the stricture, and then we'll proceed for the diagnostic cystourethoscopy with VIU in this patient, sir.
Depending upon the location.
So we cannot do in if the stricture is in the penile urethra. It will be done for the patient having bulbar stricture, that too of short segment.
So now if the patient comes with a strictured urethra, what are the different treatment you can offer him? What are
Depending
the
upon
latest
the
also and
size
the old one? So tell us.
of either initially could be a urethral dilatation, sir,
Depending upon
or
site and location.
site, and depending upon the site, and so urethral dilatation, OIU,
देखो,
VIU.
better try to avoid the treatment, urethral dilatation, VIU. Basically now VIU is now remain in very selected patients.
Yes, sir.
नहीं, इंडिया में VIU राइट एंड लेफ्ट हो जाता है, वो छोड़ दो, लेकिन थ्योरेटिकली VIU का बहुत रोल बहुत कम हुआ है. उसका रीजन ये है कि उस बहुत सारा सक्सेस रेट इतना वेरीगेटेड है कि 15% to 75%. कभी it is totally depend upon the length of the stricture, density of the stricture and amount of spongiofibrosis. The important thing is amount of spongiofibrosis. अगर amount of spongiofibrosis बिल्कुल नील है तो डेफिनेटली VIU का रोल है. लेकिन वो बहुत सेलेक्टेड पेशेंट में उसका रिप्लेसमेंट ऐसा आया है कि अभी नॉन ट्रांजेक्टिंग यूरोथ्रोप्लास्टी आ गई. वह बलबार के लिए है वो भी छोटा अगर है तो नॉन ट्रांजेक्टिंग में सक्सेस रेट इससे ज्यादा है VIU से. तो VIU अंटिल अदरवाइज बहुत ही सेलेक्टेड फिल्म स्ट्रक्चर है तो ही VIU का कमेंट करो, नहीं तो बेटर VIU को रहने दो. लेट एग्जामिनर विल आस्क. क्योंकि डायलेटेशन, कैलिब्रेशन, ये सब चीजें होती है प्रैक्टिकली बहुत जगह पे होती है, लेकिन थियोरेटिकली उसको कुछ ज्यादा अभी फिलहाल इम्पोर्टेंस नहीं बचा है, ऐसा मेरा ओपिनियन. पंकज सर, बिकॉज योर रिएक्शंस इज देयर.
अच्छा, was it so clearly visible, sir? So I strongly feel, sir, ki they should talk of one attempt at VIU, especially if it's a short segment stricture. And because a lot of examiners will accept one attempt at stricture for posterior urethral stricture, short segment stricture, and non-traumatic stricture. So to directly say that they should not talk about VIU, I, for a change, don't agree with you, sir, today.
आई एम टोटली एग्रीइंग विथ यू. ऐसा नहीं है कि मैं आपको एग्री नहीं कर रहा हूँ. मुद्दा ये है कि स्ट्रक्चर का जो लेंथ, उसकी डेंसिटी एंड स्पॉन्जियोफाइब्रोसिस, ये पता रहने के बाद में ही उसको आप कमेंट कर सकते हैं. छोटा सा एकदम नैरोड हो गया है कंप्लीट, और उसको तुम फिर भी विहायु बोल रहे हो, तो उसमें रिकरेंस पक्का है.
Fair. I agree that if it's a dense with significant bulbospongiofibrinosis and especially
very short segmental, fringy, mucosal,
mucosal,
mild spongiofibrosis, वहां तक भी मैं लेस देन 1 सेंटीमीटर. इसमें अगर आप इंडिकेटेड है तो है अभी भी.
Still, sir, because you see, it is a good idea that they should be able to discuss VIU also in exam. A lot of people may not be able to discuss urethroplasty. So if they start with VIU, some questions can happen in VIU and then move to urethroplasty. So first time stricture, they should talk of one attempt at VIU, unless it's a very long segment, then stricture, associated, say complicated stricture, they should talk of VIU one attempts.
And second thing is majority are not doing urethroplasty. So, when you say that.
Sir, I am not agreeing. India is a hub for urethroplasty. 100% urologist is doing the urethroplasty. 100%. Only the complicated urethroplasties people are not doing. But the routine urethroplasties like anastomotic urethroplasty, progressive perineal urethroplasty, बहुत सारे जितने बच्चे बैठे हैं उनको सबको पूछो, हर सेंटर में होता है.
But they are doing VIU also quite often.
Agreed, sir. I'm not denying the role of VIU. अगर वो टिपिकल सेलेक्टेड पेशेंट में VIU है, मेरे पास VIU मैं बहुत कम किया हूँ, क्योंकि उस लॉन्ग टर्म रिजल्ट्स उतने कुछ अच्छे नहीं.
Correct. So right. So in exam they should say, as you said very rightly, yes, sir, in selected cases I will like to do VIU. Otherwise, my first choice will be urethroplasty. Correct?
So short segment है ना, तो नॉन ट्रांजेक्टिंग है ना.
राइट.
जैसा अभी मिनिमल ESWL में आपके पास बहुत सारे मिनी माइक्रो सब PCNL आ गए. तो अब ESWL का नाम लिए कि ESWL तो खत्म हो गया, आप कहाँ ESWL करते. तो सेम सिचुएशन लागू है यहाँ पे.
Okay. Fine. So anyone can just tell us how will you do VIU?
सर VIU बहुत बार टेबल वाइवा में पूछा जा सकता है.
या
डेफिनेटली ओल्ड एग्जामिनर है तो डेफिनेटली VIU डिस्कस करेगा. वो मैं आई एम एग्रीइंग विद पंकज सर कि वो अभी भी एग्जाम में डिस्कशन का पॉइंट पक्का आता है. VIU मालूम रहना बिल्कुल गलत नहीं है, लेकिन VIU इंडिकेट्स ट्रीटमेंट एज अ पार्ट. इफ दे आर सजेस्टिंग द ट्रीटमेंट पार्ट, then they should be clearly know now after doing the RGU, after seeing the RGU, कि उसका स्ट्रक्चर लेंथ कितना है, डेंसिटी कितना है, नैरोइंग कितना है, ये सब पता करके ही बोलना है. नहीं तो क्या है, अननेसेसरी फिर वो गलत ट्रीटमेंट एडवाइस होगा तो उसको पकड़ा जाएगा, वहीं पे रुक जाएगा.
Right. So let someone talk about VIU and just enumerate what are the different new techniques for this thing, stricture. Can anyone just enumerate?
So there is the new techniques for stricture, sir. There is a role of stem cell regenerative therapy, sir. So
there are drug-coated dilatations as well.
And the medical coated the stents, which are paclitaxel drug coated stents, which inhibits
not stent, balloon.
Balloon.
Mitomycin
which
is
inhibits.
imported, and
Drugs being used are mitomycin C and colchicine. The research are ongoing for these two drugs, sir. As well as they are looking for the role of corticosteroids intraurethral instillation post urethroplasty and post this stricture treatment therapy.
Okay. So can one of you enumerate all step by step? Like first you say that in selected cases, sir, VIU is one of the treatment. Second is buccal mucosal graft urethroplasty. If you don't have buccal mucosal graft, then which are the other things you can use?
So yeah, we
Nakul?
can use
Well,
a lingual or a labial graft or a
labial.
bladder epithelial, rectal mucosal or tunica albuginea, tunica vaginalis flap, and then preputial graft
posterior
or
And
auricular.
posterior auricular full thickness.
Saphenous vein.
And saphenous.
Okay. So these are the grafts. Okay. Then other technique.
flaps, sir.
So
The
flap techniques,
Local flaps or
endoscopic
McKinney's flap,
urethroplasty is also
Orandi
being
flap.
done.
Ducat orandi flaps, Jordan flaps.
McKinney's flap.
So the flaps are over. Third, fourth, after that,
Augmented anastomosis, sir.
what is that?
So where we the floor or the strip or a floor at the site is anastomos, and which is supported and augmented with either a flap or a graft. So once you excise the stricture completely and then you perform the augmented.
Okay.
Or we can
Then
use even a graft and a flap
One
together, double
देखो
face.
one-sided primary anastomosis and other-sided augmentation with graft or flap.
augmentation.
Yes.
Yeah.
करेक्ट. हाँ, augmented का वो क्लियर कट है. एक साइड से प्राइमरी एंड टू एंड होगा, दूसरा साइड को लेंथ बढ़ जाती है ज्यादा है, इसलिए उसको फिर ऑगमेंट करना पड़ेगा ग्राफ्ट से या फ्लैप से.
Even both we can use graft and flap double face.
बिल्कुल कर सकते हैं डबल ग्राफ्ट और वेंट्रल फ्लैप, और एक साइड से ग्राफ्ट एक साइड से फ्लैप, दोनों साइड से ग्राफ्ट दोनों साइड से फ्लैप, ऐसा सब चीजें डिस्क्राइब्ड है.
As well as, sir,
बीएमजी बोलने के
substitution
बाद में
और
इमीडिएटली प्रीटोशियल स्किन बोलो और शिफानस वेल लास्ट बोलो, नहीं बोला तो भी चले.
Yeah.
And sir, and even if it is a pan-urethral, non-reconstructible, and too bad urethral plate or scarred, then there is role of perineal ureterostomies.
उसके पहले टू स्टेज ऑर्थोप्लास्टी बोलो.
Bracas.
पेरिनियल यूरेथ्रोस्टॉमी इज लास्ट रिसोर्ट.
Yes.
बाद में बीएमजी डॉर्सल वेंट्रल लैटरल सबका रिजल्ट एक सारी का है, थ्योरेटिकली प्रैक्टिकली और लिटरेचर वाइज आल्सो. थोड़े बहुत बेनिफिट्स ये है कि जैसा वेंट्रल कर रहे हो तो इजी ज्यादा यूरेथ्रल डिसेक्शन नहीं करना पड़ेगा, ब्लीडिंग कम होगा, टेक्निकली इजी रहेगा, यूरेथ्रल डिसेक्शन कम रहेगा. डॉर्सली है तो सैकुलेशंस नहीं रहेंगे, ग्राफ पक्का बैठने फ्लैट बैठने के लिए इजी हो जाएगा. ये माइनर पॉइंट्स है, लेकिन उसमें उसकी वजह से रिजल्ट्स पे कोई चेंज होने वाला नहीं.
Good. So other newer technologies, just fatafat enumerate and we finish.
the substitution urethroplasty has been described by using the sigmoid colon also.
Mm-hmm.
बावेल इन
Then
यूरोलॉजी.
Babel. Come on, fast. What else
So
then?
Now,
in his drug
endoscopic
coated.
endoscopic
One. Omar, you
urethroplasty is
say.
also being done.
Which one?
Endoscopic urethroplasty is now being done, sir.
So
Okay.
means
Tell us what is that?
buccal mucosal graft has been
Sir,
placed at
just
the
like
site of the VIU.
yeah.
Albec.
Come on, one of you say, Omar. You say, finish it off. Let Omar say whatever he wants to say.
Sir, just like a VIU, normal VIU, VIU is done, and over the catheter, the graft is placed, and it is just fixed over the incised cut area of the VIU.
How you do it?
So the exact procedure, I am not aware of it.
So
So
first of
before
all,
that,
it
we
is
have to
two-step
take
procedure,
a
sir.
1 centimeter strip of the buccal mucosa and then give for the culture, and they prepare in a solution, and then after that you have to instill.
So these
There
are
are
the two
two
different
techniques.
techniques.
There
One
are
is instill,
basically
where
two
you cut
techniques.
it and put it, and then you put the Foley's catheter. But what he is telling you is to take the graft, put it on a. First, you have to find out from where to where on the Foley's catheter
Scopes.
you are going to put. Okay,
Okay, sir.
where
Yes.
the stricture is, and then fix it on the Foley's catheter and put the Foley's catheter so that this graft goes exactly over the inside part.
Okay, sir. Yes, sir.
Okay. Anything else? Pankaj bhai, Vinod bhai, anything else? Newer technology?
What is robust trial?
There was a brief mention about urethral stains which were out of use. I don't know whether it is worth mentioning or not. I have never used it. Maybe Pankaj must have used it. I think I don't know.
Years back, sir, when I was at RG, but not for last 20 years. Yes, there used to be urethral stents. The company was called as Instent.
Yeah.
So you would do a VIU and place these stents. So those stents would keep the urethra open. The major problem with those stents was, one is mucosal overgrowth and second is migration of the stent. Second, these patients would have significant pain or bleeding at the time of erection. So most of them did not work well, so they have gone in disrepute, so no longer used today. Today, the thing which is really fascinating, especially urologists in US, is the Optilium balloon.
Yes.
So it is a paclitaxel coated balloon. The advantage of paclitaxel is it's an antifibrotic drug. So once you cut and inflate this paclitaxel get coated to the cut area and prevents refibrosis.
Yes.
So I asked about robust trial. Anybody knows what robust trial
Sir,
is?
it is to compare these results of this using Optiloom with these plain VIU. So they have found out that there is recurrence rate has decreased after using Optiloom.
Yes. So there is robust 1, 2, 3. Robust 1 was the initial trial done in, I think, some Latin American country. Robust 2 was the initial trial in US, and Robust 3 was a comparative trial between VIU and Optilium, and where they saw that the 3-year patency rate was nearly, if I remember it right, around 70 to 80%. So they have found, so that is how they have got a FDA approval for this Optilium for urethral stricture.
Any comments on laser VIU versus cold knife VIU? I think people will probably ask this in the exam.
So literature shows no difference between the both. So results are similar, sir, between the both.
Result wise?
Result wise, both are same, sir, but laser has an advantage that it can be used in anticoagulated patients. So we can get hemostasis as well in the intra.
I just did it a few days back. One patient was just post PAMI and he was on blood thinner side. We did a laser VIU.
Yeah, I don't like laser VIUs because I think that it generates a lot of heat energy, giving rise to definite stricture formation, but the opinions can differ.
Yes.
So at best, it should be considered as one of the technique of cut, and results are as good or as bad as standard VIU. So yeah, with a probable small place where in a patient who has bleeding tendency or antiplatelet, anticoagulant, it can be used. So initial studies, I think the paper was by Akhil Das, where he excised the complete stricture.
Yeah.
And in his initial reports, he had presented it as an alternative to urethroplasty with a more than 70% patency rate at the end of 1 year. But over time, laser VIU really does not have any advantage.
the gold standard will be
Gold line.
urethroplasty.
Absolutely.
Yes.
Yeah. So please, all the students understand that what is the gold standard. Okay. And now you know everything, means quite a lot about in urethroplasty and how to answer. So thanks to all our teachers. And if you have got any queries, you can put it on a group. Special thank to Vinod Bhai. Thank you, Vinod Bhai, for joining and be
Yes.
with us till end.
Yes. I'm going to attend
Okay.
regularly. I plan to.
Thank you,
Thank
sir.
you.
Thank you. Thank you. Yes, thank you, sir.
Good night.
Thank you, sir.
Okay. Good
Thank you,
night.
sir.
Good night.
Good night.
And students, you are really doing very well. I'm very happy. And at a time, 3, 4 are answering. That shows your enthusiasm. And yet the new students, they have to come. So I'm sure that our viewer will be much, much more than what we are having at present. So thanks to all of you. See you next time, next Wednesday.
Sure, Gaurang. Good night.
Okay. Good night.
Very much. Bye then. Thank you, Dr. Gite.
Yes. Gite, you were excellent today. Thank you.
He left, I think.
Yeah.